Well, hello, everybody. Welcome along to the Institute of Health and Social Care Management. And this is our Integrated Care Special Interest Group meeting for January. Happy New Year to Le Monde. Hope you're going to have a fantastic one. We look forward to seeing numerous subsequent events to today. And today we are absolutely delighted to kick the year off in fine style. We have Miriam Lemar from Libera Partners and Kris from Neon Health Solutions. And they're going to start the meeting off by talking to us about delivering sustainable cross-system working. Can't wait, you two. I'm sure this is going to be fabulous. I'm going to hand straight over to you. Thank you very much.
So I'm Miriam Lemar, as John has helpfully introduced me. I'm a management consultant, ex-PwC many years ago, but have been working, I founded Libera Partners along with some other folk a number of years ago, over a decade ago, with a focus on integrated care, which is a bit of a concern since that was over 10 years ago and we're still talking about it. So, but lots of learning under the bridge and since then. As a result of that, I've done an awful lot of work in primary care and within the community as well. So that's me. Kris, do you want to introduce yourself?
Thanks, Miriam. So my name is Kris Glover. I've been working in healthcare for about 15 years now. Also management consulting as a background. So I worked at PwC with Miriam. I've also worked at Ernst & Young. And more recently, the last 5 years, I've spent trying to develop technology around data analytics, around capacity and demand planning, and around options modeling technology that will really enable us to support management consultant type approaches to delivering work. Very much focused on secondary hospital care, mental health, and so my skills and the skills we bring complement, I think, very well with Miriam, and different skills, but different backgrounds, but trying to focus on the same kind of issues. So,
yeah, and I think so it's one of the reasons we've come together, which will hopefully come across as we speak during today. So what we were going to do was, it's on the next slide, I think. Our aim today, because we've got, I think, an hour, maximum of an hour, we thought we'd obviously do some introductions, find out who's in the room, as it were. And then we thought it might be helpful, and it's a very quick overview of the operational plan. Some of you may have had time to digest it by now, but since it came out on the 23rd of December, we thought it might be useful to do that. And then we thought we'd talk about what our kind of approach and what we think needs to happen in order to be able to deliver that, really. But one of the things we're trying to achieve with today is to have it as an interactive session rather than just listening to us blather on. We thought it would be good to get other people's perspectives as well. So one of the things we've asked, and hopefully Jade has it, we've got a little poll just to find out who's in the room, as it were. And so we'd be grateful if you could fill that in. And in fact, it's looking as though we've only got about 4 people there. I think we were expecting about 40. So, but if you could just quickly fill that in, that would be great. Are you going to do that? Thank you. So, does it come up?
Sorry, it says I'm logged in from another device. I think John's got the rights at the moment, so John can pop on polls. That'd be great.
It's up. It's definitely working.
I've got mine up, so you can probably see mine on my shared screen.
No, you're fine.
Okay.
You can't see the results. Okay, the best laid plans. Can you see the results, John?
I can, yeah.
So Kris on shares, perhaps you could share.
So we've got a couple of technical people along here. We have most of us are managerial and half of us are leadership. And the type of organization is a real mix. It's all sorts right across the piece, as you might imagine.
Yeah,
that's
okay.
perfect to have that mix across everything. So it'll be good to hopefully get some good discussion later.
And in terms of ICS planning, lots of us supporting strategic advisory roles are not applicable. That might be me.
Yeah. Okay, well, that's really helpful to know. So on that basis, some of you may have already read the operational guidance, but if we just quickly go through where that's at. Oh, great, it's appearing now. Thank you. I should say that any of the slides, etc., will be shared, and also I believe there's a recording of this, so that will also be shared afterwards as well. Now, 2 seconds while so one of the things we wanted to do, actually I've just remembered, was to use the Miro board, because we thought that might help with some of the conversations, as it were. So hopefully, I'm just about.
Can everyone see that? So I'll just share this so that we can, for those that haven't used it, can just sort of see it before we start using it in anger.
Have you used Miro before, any of you? No. So hopefully I've put the link in the chat, and you should be able to click on that, and that will bring you to the board. And Kris is just showing the what the board looks like, and I just need to find it because I've lost you. And basically, it's a massive whiteboard. And what we've done is we've set it up so that you've got, I can see a number of you on there now. So we've set it up. I've put a play frame on there so that you can practice using it. And then we've got basically 3 questions, and we thought we'd use it as a way of capturing people's ideas and having a discussion. So we're going to use just it very simply. I've piled up a load of Post-it notes on the top, which you can just drag and put onto the playboard. I think Kris is doing that now. And then on the left-hand side, there's sticky notes, which you can complete. You can basically use and pull them on if you've run out on the top. If there's any questions, let me know, but hopefully you'll get used to it quite quickly. And I'd appreciate whether knowing from you if that's been helpful or not. Okay, Kris, can I go back to the slides?
Of course, there we go.
So to go through the operational plan, I started trying to draw it out on a piece of paper to try and think about how I could get it all onto one page. Hence, what you've got here is the way it's presented. So as you'll be aware, the priorities and operational guidance was issued on the 23rd of December. And what they were aiming to do as part of the this one is to have a shorter document, which they succeeded in doing because it's only 20 pages. They're normally a lot longer than that. And the aim was to also reduce the number of priorities that the NHS has to deal with this year. I'll leave it up to you to decide whether we've actually managed to achieve that at this point. What this diagram is trying to do, though, is just to fundamentally replicate what was in the document. So that's what I've used their terms. Some of the terms like tasks, objectives, and actions, you might have some views about whether they're in the right order, etc. But I'm just reflecting what was in there. So they've got 3 tasks. If we're on the left-hand side of the image you've got in front of you, which is about the first priority being about, or the first task, I should say, is about recovering core services and productivity. And the second and third are around delivering the long-term plan and NHS and transforming for the future, which they're kind of related, you would think. And then the second set is about the tasks that are then related to the objectives. Now, the objectives are the list of things, which I think we in general knew about already, you know, things about, it's page 7 in the operational guidance. And we actually, on the slides, I have a blown up version of it so you can read it. But fundamentally, it's about, you know, sorting out urgent and emergency care. It talks about increasing the number of appointments and primary care, making it easier for access in primary care. It talks about cancer rates, talks about children and young people, improving maternity services, etc. And my sense is I think we knew about a lot of those things already, but obviously we've got to deliver them. And then the actions that follow on from there are all about, they said they're evidence-based actions. So they're talking about reducing bed occupancy, reducing ambulance handover, which has been a lot in the news recently. But the majority of the rest of it is about increasing activity. So it's talking about doing more, which is a bit of a concern given the pressures in the system at the moment, and the lack of capacity that we've got. But I think one of the things that we would say is we need to possibly think about how we do things a bit differently. And I think that that's quite key to doing this.
Of course, there's some real challenges in here when you sort of start to look down at the specifics of this, in increasing elective activity by 30%, whilst also reducing bed occupancy down to 92%. Some real sort of hard targets in there that are not going to be simple to achieve, all across a sort of a background of more integrated care, which is clearly the opportunity to be able to deliver some of this stuff. But it's incredibly sort of complex, integrating care across multiple systems and organizations. As Miriam alluded to earlier, this is something that we've been talking about for years. So some big challenges here.
Yeah. So what John, you said, I see virtually nothing in the priorities. Well, I think that this is interesting, is because I think that the priorities are probably all here, which you then think about, well, what are the priorities? Because there's so many. You kind of have you got, what are they? You need to have minimum ones, don't you? So but I think that's a really important point. It's interesting to look at the documents, actually, because as Kris and I have been going through them, they look at quite straightforward in an initial view, but actually they feed off into all sorts of different areas. Yeah, so they've achieved in one way to reduce the length of the document, but it's actually, have we got a coherent set of priorities? So we've got 2 and 3, which is around the long-term plan and the objectives around that. It links into the long-term plan are our objectives, and there are North Star. Well, the long-term plan, as you'll be aware, is quite a long document as well. And it talks about many of the things that are here that they reference as part of Transforming for the Future, which is a focus on prevention. Thankfully, because it's something I'm quite passionate about, that the right digital foundations, workforce, which I know John was writing about this morning, and continuous improvement. The interesting thing for me about these actions is actually where they end up within the new organisations. So you can see that NHS England are taking responsibility for producing something around continuous improvement for the whole of the system, and also they're taking responsibility for the workforce plan, which some people will think has already been done, but is sat there, I think. So they're taking responsibility for that. And I think there's also, which we haven't put in here, but there's also talk about an access plan for general practice, which we haven't seen yet, which is likely to impact on a lot of this. And then the other things are working NHSE, and I think the regional teams in the majority, working with the ICSs to produce things around prevention and effective management and the right digital infrastructure. So we're starting to see how some of the responsibilities are manoeuvring are likely to change in the new system. So I think that's important. The other things, and you could argue that these are objectives as well, is that there's a theme through the document. If you look up in the right-hand corner at the bubbles or the clouds, which talks about greater transparency and local empowerment. So we're talking about more agency for leaders and including patients more. And there is quite a focus on some of the stuff that we're reading now about having more greater local determination and improved system flow, which is music to our ears anyway. But I think that's quite important.
I think one of the things that certainly, Miriam, we've been talking about as we've discussed this is about getting the focus on all of this, because there's so much in here, and as John said, there's there's so much in this priority list. And so we're trying to sort of then bring that down in terms of how do we focus, and do we take a particular pathway, do we take a particular sort of cohort of patients and follow those through the system so that we can understand how we can embed all of these kind of principles and sort of opportunities, but in a more managed, structured, focused way. So, trying to get focus out of that massive list of priorities.
Yeah, well, I've just had a chance to read John's chat comment fully, and actually I agree with you completely, John, in terms of the social care piece, because it's not strong enough the whole way through it, and even in the operational framework for NHSE, which I'll come on to in a second, it's there, but it's not really, it's just not embedded well enough. I agree with you. We're trying to think about how, if we're working as a system, that's part of the system. They may not be in the NHS completely, but they are part of the system. And that's a complete mindset change, I think. Personally speaking, I'm quite passionate about that.
Just conscious of time as well.
Yeah,
Should we move on? I think there's so much to do, isn't there? And we're at risk of sort of getting bogged down in all of this detail. But
so just one thing to just say quickly while Kris is changing slides. Some of the things that come out of the operational framework for the NHSE is about co-creation and collaboration. And co-creation for me is not only creation with staff and frontline, it's also with patients, guiding a lot of that. And I think that has got to flow as a theme through everything that's happening. Okay, sorry, Kris, you go ahead, because ICBs have to produce a joint forward plan, and Kris is going to take us through what that's about.
So I won't labour this slide. As we said, we will send the slides out. This is as much for sort of people's, to distill what's in those documents. The framework here just sets out the timescales, the key stakeholders, and the key sort of requirements of the planning. And there really isn't that much time to sort of get underneath the skin of this. Clearly, there is a huge number of key stakeholders across an integrated pathway. So some real big challenges here to build a plan that's not just sort of paying lip service to the legislation, but really does start to look at changing behaviours and changing the way in which healthcare is delivered across all of those different elements. And I think, coming back to your point, John, when you look at the ambulance ways at the front door, potentially one of the solutions to that is managing the flow out the back door. So, we've got this big opportunity now to look at integrated care, but part of that challenge is understanding where the sort of actual problems sit, rather than just looking at where they're manifesting themselves.
Yeah. And I think the other thing about that joint forward plan is that there's an expectation that it links in with the health and well-being, board, etc., and with the strategies for I've forgotten what the acronym is, the joint social and health and well-being board strategies. It's mentioned, I've forgotten it, but fundamentally to me, I think about, well, aren't they the same thing? What are the differences? Surely one is a subset of the other, but that's something to be thought about, and I think that plays into your point.
Yeah. Just to comment, Paul has just put a comment on to say how can duty to innovate and duty to have regard be assessed or evaluated. And I think this is part of the challenge, isn't it? It's that we need to sort of look at delivering change rather than just ticking boxes against a sort of framework or a document. So it's sort of bringing this to life in a real change that is going to make the big difference.
Yeah. So I think I'm going to put the link to the Miro board in again, because I think we're moving on to that next, aren't we? What's the?
Yes. So this quote just sort of sets up that Miro board. Is, you know, if we do what we've always done, then we're going to get what we've always got. And you know, the question on the first question for the Miro board is, you know, we've got this opportunity with the operational plan and integrated care. So what are the opportunities that are presented by this? So we just wanted to get as much feedback and thoughts here so that we can have a discussion on this. And I think what we're going to do, Miriam, is have 2 minutes for people to write their thoughts down, and then we had said 10 minutes to discuss. I'm not sure we'll quite get that much time, but I don't know if you can set the clock. We can have a clock. We can use the technology.
There. Yeah. So is everybody comfortable? Yeah, great, good. I can see people starting to use it. So the stickies are on the top. You can pull them down and just type on them, or on the left-hand side, you'll see the square with the folded up triangle. That's another sticky if you want to be able to use that as well. So it would be great to see some things coming on here. Oh, wow. Oh. Is everybody managing all right?
A few shakes of the head. Are you struggling, John?
Are you? I think John's point is very sad.
Mm-hmm. Yes, I'm sorry. I'm not trying to come across as the gloom monger here, but I despair of this document. It's in my view, it's absolutely not what was required. It's a huge missed opportunity. If you actually speak to people doing the stuff at the front line, this is miles away from their daily priorities or even experiences. It's just I think it's futile. I find it, I'm really angry about it, actually, if truth be told. I'm not trying to take away anything from your presentation, which is fantastic, but the document itself, goodness me, what a nonsense.
And I think, John, we've, you know, Miriam and myself and others, as we've been discussing this, have been, I guess, trying to be optimistic about the document and trying to sort of leverage the bits that we can leverage from it to say, well, let's take, you know, as I said, let's take a pathway and really sort of embed all of the sort of best practice that we can find about that pathway. Let's get everyone in that pathway talking so that we can understand, you know, how GPs hand off to secondary care to, you know, social care, and we can really understand those pathways in detail and build an evidence base and a sort of use the technology, use sort of organizational development techniques and so on to bring everyone together so that we can genuinely make a difference, and then to try and sort of expand that and embed it across more pathways and develop further.
Yeah. So yeah, I mean, in a way, I look at this and I do most of my works with PCNs and primary care, and almost every single thing on it will impact on primary care in some way. And I'm thinking it's about broken now. So, you know, adding more to it isn't really going to help. So, but when, yeah. So
I like that comment about moving away from hospitals. You know, they seem to be a solution that is not making the best of what's available now, and doesn't meet the requirements of patients and society as a whole. If you're really sick, then hospital is the best place for you. But for everything else, there's a real challenge in my mind as to whether you should be anywhere near a hospital.
Yeah. So should we move on then? Because what we were thinking about was actually we need to do things. We've been paying lip service really to doing things across the system for a long time. And certainly many of you will have experience of trying to do this. So it'd be interesting to get your perspectives. But it's actually trying to align so many different things in a complex system. It is quite tough. But should we move on to the slides again then? If everybody's finished on there.
Is everyone finished? Yeah, just talking about virtual wards, which is interesting because I'm certainly interested in knowing more about virtual wards. It strikes me as being a good opportunity, but obviously not in all cases, and it's trying to understand which cases they could work really well for.
It's one of the latest things, isn't it? We'll have virtual wards, but what's the context? What's the objective?
It is the the latest thinking, but we've also had this in sort of end of life care in the past, where there's a real sort of pull towards the hospitals, which doesn't necessarily fit for everyone. For some people, it might be right. For others, it's not so much. And it's from experience, it's very difficult to sort of move away from that sort of traditional approach of hospital-based care. So.
Yeah. Okay. All right. Thank you for that. I think keep filling those in, because what we'll do is we'll capture them and we'll put them in the slides so that they can then be circulated afterwards. And we'll also capture what's in the chat. I'm sure Jade and suitably qualified, but I'm sure we can help with that as well. So
as Miriam says, we will continue to capture this, so do keep putting stuff in there, and we'll commit to sort of bringing that together and adding it to the slides when we send those out. So it'll all get sent back to you. You'll capture everything that we capture.
Okay.
So we put this slide in for two reasons, really. One, because we just quite like the visual sort of graphic side of it, and we like the way it sort of set out the NHS as a big set of interdependent sort of systems, and it just the challenges of moving across those boundaries with any sort of solutions is going to be significant, and it's going to be a real part of embedding change. The other reason we quite like this slide was because it helped us to sort of show those elements that are outside of the traditional sort of hospital GP setting, looking at things differently, looking at self-care, looking at how technology can be sort of used to support patients, looking at how we can use different settings. Obviously, sort of supermarkets are starting to be used more and more as a sort of a place of whether it's getting blood tests or whether it's having mobile units set up in the car park. There's all sorts of opportunities to look at things differently, both nationally but also at a local level. And what works well in one locality might not work in another locality. So this slide was really just to sort of get some thoughts going around that sort of interdependent system.
Yeah. So I think one of the other things is that what brought us together, I mean, Kris and I have known each other for a long time, but both my work has been mainly in the out of hospital space, if you like, and Kris has been mainly in the hospital space. And when we were talking, we realized that tackling something like outpatients, for example, the work would typically be done within the acute. Well, from my perspective, I was thinking, well, actually, the patient journey starts a long time before it gets to the acute. So actually, what we're trying to do in some ways is, in a way, is mirror the silos and the tribes that already exist. And what we find with our discussions is actually it's giving us the opportunity to think about, well, actually, what would we do if we were in somebody else's shoes? So because we've both got slightly different focus, and that's quite interesting even of itself. But it's really important that that we look at things from a system perspective and look at it with the patient right at the center of it. And that's kind of what we're trying to do. And I think the next slide, if I just go on to that, because we want to come back to some other questions, is what we were trying to get to is around, we need the data. We need to understand what the data is telling us, but above all, we need people to work with people. And actually, no change is going to happen unless we can support better relationships and more trust across the different silos. And actually, that's key to what our suggestion and what our way of doing things is really about starting to get people to start talking to each other. So if we took the example of referrals, it's actually how understanding that patient journey. This is what this slide is trying to say, but it's about, we need to understand what's happening with the patient and where it's going wrong. And my perception is it's usually in the handovers. Often we get brilliant care at that point in time, but it's the handovers where things are going wrong, notwithstanding everything that's going on at the moment. And clearly there's massive issues at the moment, but it's...
Just on that, sorry, Miriam, for jumping in, but there's massive evidence across all industries around sort of error rates and handovers, and the error rates at handover points goes up significantly. And when you look at the care system that we have, where there are so many handovers, and particularly if you look at those sort of pathways, if we look at a diabetes pathway, for instance, a patient may well have most of their care within the primary care setting, but then as they have flare-ups or go through different stages of their sort of life, they may have episodes within the acute sector or other sectors, and yet those sectors don't know, the different care elements don't know about what's happening in the other. And so the patient's sort of trying to navigate a system. The doctors don't quite know what's happening in different parts of the system. So it's those interfaces that cause a lot of the greatest challenges. We have interfaces where those clinicians no longer naturally talk to each other, and we've got to change that. We've got to find a way to be able to sort of manage those interfaces much better.
So there's some really interesting points being raised in the chat, and thank you so much. So I'm delighted to see what Jane has said, making consultants and GPs talk to each other, and actually thinking that more about the budget needs to be looked at as well. But I think we do need to think about how we get people together. And Malgwan, sorry, I'm not very good at pronouncing names. So that was a very valid point as well. And John makes some very good points about public health, and it is all about the system and looking at things and that journey across the system. It has to be, because my background originally in my life was sort of as somebody who was developing systems, technology. You actually talk to the users, and there are lots of different users in the system. So the users are the patients, but the users are also the staff. And if we can get some of that right, then we can put the right technology in place. And actually, there will be some simple solutions, because if we talk about helping patients with self-care, but then we don't provide them with the information they need. So, if you do some simple things like look at GP websites, how do you find out how to raise a sick note? You'll find it eventually. How do I find out how to look after my sick child? Can I give them Calpol and Nurofen at the same time? Where is that information easily available? So there's some other things that can happen, little things that can make a difference to help as well. Okay, there's some fantastic comments coming in here. Sorry, I can't keep up with them all. So was the key problem, namely dealing with hospital activity. Problem is, even if the hospital was running brilliantly, you were still throwing the interval back. Yeah. I think that, but this is, again, it's about looking at the whole journey and thinking about it as a whole and how that actually fits together. And that kind of leads on to John's point earlier about social care, you know, but even if we bring in social care, then you've got to think about the third sector. You know, are you within social care, are you including the nursing homes and domiciliary care and all of that as well? So, and actually, is there capacity within that? And that, I mean, so the thing is it is a massive problem, and fixing it in one area will give some consequences in another. But if we were to be aware of that, cognizant of that, and think about, well, we've sorted that bit out, now we need to think about how we move on to the next bit. But I guess what we're trying to get at is actually, these are our key points. Really, we need to think about it from a system perspective. We need everybody to be working together. And I know there are vested interests and all the rest of it, but we've got to, you know, have we got to the point now where we're on our burning platform and we need to do something differently and actually tackle this in a different way? And that surely some of the things that are being talked about and sort of the excitement around ICSs in the first instance were about driving change from the bottom up, for the want of a better way of expressing it. And that involves including all of these different people. Yeah. So, sorry, I'm on my soapbox now.
Yeah, a big part of that, Miriam, as well, is also looking across the country at best practice, and sort of Northumbria Healthcare Acute Trust are starting to get into that sort of social care space and starting to sort of take ownership of that to enable them to sort of manage the acute care. Because it's so fundamentally linked. So, you know, there's a lot of good practice out there. I think one of my frustrations over 15 years of working in healthcare is that we have these pockets of best practice. And the challenge for me is, how do we take that best practice and embed it so that it's business as usual, so that it's much more sort of widely taken up. And I don't quite know why best practice isn't more readily sort of seized upon within the NHS and sort of delivered more widely. I can't quite get my head around that.
And John's made the point about we need more capacity in the system, and I don't disagree with that at all. But in the short term, something's got to change, and I think there are opportunities to do some things differently. I absolutely agree, we need more staff, but it's then thinking about how do we do things a little bit differently that can actually impact on maybe what some of those staff, what some of those skills should be like. I'm personally, I'm very bought into we need prevention and well-being, because I think we can teach people, or people can need to be doing. I'm one of these people who believes that exercise is the cure for everything. So, yeah, so I think there's something in that. Kris, do you want to go on to the next slide, and then we can go back onto the Miro board, because some great ideas coming out here.
Great. So this is a slide that we put together in terms of the proposition that Miriam and I have been talking about. Fundamental to my work is around embedding technology, and you know, as I said before, that's around data analytics, it's around capacity and demand planning, and it's around options modeling. And the way in which we develop our technology solutions is very much sort of integrated with the sort of management consultancy approach. And it's about using technology to really supplement that, rather than technology being the thing in itself. We spend a lot of time really understanding the data, but without sort of shifting that challenge onto clients. So we spend a lot of time sort of unifying data, and that's particularly important in this kind of challenge around understanding all the different data elements coming in. More importantly than that, though, is supplementing and adding layers onto that data, so that we're not looking at data without the context that goes with it. So we need to understand the context, the targets, the system structures, what's the geography of the system look like, where do the where are the different places within the system, so that we can understand and really sort of validate the data and understand it in a way that makes sense. The next step on that is to really explore the data and to use the data to then guide the sort of focus of any implementation plans. And this we find really supports collaboration, because it enables everyone to sort of coalesce around understanding what the big areas of opportunity are. So, which pathways use the most resource, which pathways have the most number of patients in them. So if we can start to focus on this in a structured way, then we can get most sort of benefit for the least effort. And at the moment, there isn't enough effort, in the system, enough spare capacity to be able to focus on everything. So we can use the data to really sort of help focus on that. And then the options modeling is really around testing out sort of new ways of working, different ways of working, and particularly across boundaries where, making a change in one part of the system may save somebody else money or may save somebody else effort, but it might not save me effort here. So we need to understand what that integrated sort of system looks like, so that we can model it and then start to understand how the sort of money needs to shift or how the resource needs to shift, so that as a system we can get best value, we can support patients in the best way, but we can then put the resource where it's needed. So that sort of modeling capability is really important to be able to sort of test out options without having to sort of set up real life tests on the ground. Once we understand what we're trying to do, then we can move forward with a real test pilot and so on. So this is our sort of solution based on technologies and building blocks that we've already got. So all of this is relatively quick to sort of put together from a technology point of view. Sorry, Miriam.
Yeah, no, there's been some interesting comments in the chat while you've been talking. Before I go on to the data one, there's been some interesting things about the need for a workforce plan. And personally, I don't think we have enough focus on the prevention agenda, and I think that's something that's really quite important. And having those conversations also with the public. I don't see much of that, because somebody used the comment about rescue and respond. That's what people expect. Whereas actually, I think there's some conversations, and I don't know where they need to come from, public health or other areas. But we, as a collective, need to start talking about these things and getting people to think about how they can help themselves. And the workforce piece, I think it is about retention. But at the moment, I think you're hinting at the fact that some people, everybody's so exhausted that actually people are going, and there's other blocks in the way. There is recruitment required, but retention is a big problem as well, and planning some of those things through. And then John has talked about.
I've just read that. Shall I take that, because that's a great point, John. And it's something that we've talked about. We've obviously got a lot of experience of managing secondary care data. We know that very well. We understand it. And one of the challenges that we've talked a lot around is how do we then sort of integrate that with primary care data and so on, to get that sort of single patient record all the way through the system. Now that's our ideal world. If we could get that integrated data, then we could do some really sort of powerful things with it. However,
other countries have this, Kris.
They do.
Why has Britain so fundamentally and consistently struggled to find a way to do it.
Some of it's about handling the IG issues. We could have a whole session on this, couldn't we?
We could.
Yeah.
So my view, for what it's worth, though, is that getting around those IG challenges, we need to have a very compelling reason as to what data we want to collect and how we want to manage it. And it's right that we do that. Our view in terms of this data piece that's we're showing is that we can take data from acute trusts, we can take data from primary care settings, and we can keep those data sets separate, but we can still derive a lot of value from them. We can integrate them in and unify them in different ways. We can use that to really show where the benefit of a unified data set would be, so that we can then sort of give credibility to a pilot to bring data together in a much more unified way, so that we could then get data across different organizations with a linking element, so an NHS number essentially for patients, but without patient identifiable information beyond that. So we can be quite focused in the data that we're then requesting, and then build a unified model. So I think there's a phased approach that we can take here to really sort of prove that there is a real value to doing this. We can get patients involved in that and understanding it and agreeing that that's a sensible way to use patient data, but without going for a sort of, we just want all the data first approach. Does that make sense?
It does. I'd just go back to the patient. Say to the patient, right, here's a PIN number. It's your PIN number. And there's a little console in a nursing home with a domiciliary care provider, acute, primary care, wherever you may take yourself. And when you get there, you put a card, or you just put your PIN number in and an identifier, and there's all your data. I've given you access to all of my data. They do it in Australia, Israel, I think Canada now, all sorts of other places. Why on earth can't we? In my view, completely hopeless lack of leadership and commitment to make this happen. We just breeze from one priority to another with the wind, and it just gets forgotten about. And then we come up with more extraordinary documents like we discussed at the beginning.
Yeah, but is some of it fear about putting that patient in control?
Yeah.
Because that's what, it's making you as a patient and as a citizen responsible for your own data. And we saw what happened in November when they tried to make data available to patients through, I've forgotten what it's called, prospective access in primary care. And actually an awful lot of people were very keen on doing that, but saw a lot of risks, and the risks weren't being managed very well. But leaving that to one side, there's it has to be about us as citizens being in control of our data, and also then providing that information surely to the people that we're interacting with, and having more control. And at the moment, as a patient, as a person in the system, what level of control have you got? I mean, it feels in some ways like you.
It should. The view should be it's my data, it's my permission.
Yeah.
But let's enable that to happen. The technology is straightforward. And it's been done. We've got wonderful people who started it here and then got poached by other countries, or they got sent out from here because they just got public opprobrium. It's madness.
Yes. Well, then it's trying to think about, well, what are the vested interests, shall I say, if that's the right way to phrase it, and actually think about, but it's about thinking about some of those things in advance as well, isn't it? And thinking about how you put some of the mitigating actions in place in order to be able to manage them. I mean, just to build on your point, I did a big workshop across a system where I had everybody from literally across the system, all the voluntary sector, volunteers, etc. there. And one of the points made by one of the patients was, there's, I'm going to get my numbers wrong, but there's 3,680 hours in a year. I spend 3 hours in clinical appointments. So the other 97 hours, I live with it. So I need the tools to help me manage my own care.
Yeah.
That's the key to me. Anyway, sorry. So how are we doing for time? Should we?
We've got 10 minutes left.
We've got a couple of things on the mirror board. Should we go ahead with that?
Yeah. So the next question is, what do we do well that we need to build on? And I think this is, back to that sort of best practice question. So, let me just scoot across here. So this is an opportunity for everyone to just sort of put those single issues that you just think would absolutely change the way that we sort of deliver care.
Miriam, could you put the link in again in the chat, please?
Oh, yeah, yeah.
Way back now.
Done. Yeah. Oh, I didn't put the timer on. Sorry, I was reading Jane's comment.
All right.
Some good stuff coming up on the board. Yeah. Ooh. So, Kris, are you going to?
Yeah, so some good comments coming through. What about liberating primary care and stopping the nonsense of a 20+5 contract? I've not come across 20+5.
That's it. Well, I think there's something about the contracts just generally. There's too many itsy bitsy bits of money going into primary care, is my personal view. And actually everybody's chasing the money and focused on actually delivering against those, and obviously the care.
This is something we were talking about yesterday, isn't it? This sort of the funding, is it sequins, and do they use sequins in primary care?
No, not we've got IAF and QAF, and then lots of enhanced access, and then we've got stuff from public health as well. So there's lots of bits of money coming from different places. So so there's some really interesting things. Jane, sorry the board isn't working for you. So what if you said there's a, I agree, that you think there's a great opportunity to work on the ground. And I think that's actually where it's got to start from. Yeah. I've been working in primary care for an awful long time, and people say, what I found is that commissioners actually desperately want people like primary care to come in with ideas as to how to do things, but primary care don't necessarily know how to go about doing that. I have to say I'm starting to foment a little bit of revolution and say, come up with the ideas, because at the end of the day, it's going to be within the priority somewhere, and beg forgiveness afterwards.
Yeah.
Because you will be successful. Some things won't succeed, but obviously other things will. And on the basis of that, you need to give things a go.
But wasn't that one of the really powerful things that came out of COVID, was when, COVID hit, you had A&E departments where, clinicians were just going through the department with a roll of tape, sticking tape on the floor saying, it's sort of clean side, dirty side. It's, just making things happen and completely changing the structure, the layout, the flow of their services for the better. And sometimes it's taking that approach, isn't it, of just sort of embedding things and then sort of getting that forgiveness afterwards.
Yeah, I think we're just out of time, actually. Please feel free to continue using the board, and whatever goes on there, then we can share with you afterwards. So,
just on that, so there is a third question. So if people do want to add to it, it's around what do we need to do to support patient self-care? And I think this is a really sort of important part of this. So if you've got thoughts and views, then please put them on there. We'll distill everything after this session and then send it out to you all. So.
Yeah. Thank you so much for your participation. It's been great from our perspective anyway. We've thoroughly enjoyed ourselves. So I hope it's been helpful for you as well, and we'll send the output around afterwards. John, do you?
Just our thanks to you both, to Miriam and Kris. It's a bit of a gallop through, and the world of integrated care is not an easy one, as we've seen. I'm appalled by the report of the 23rd of December, the plan around priorities and operational planning guidance. I think it's just utterly futile nonsense, and they should be ashamed of producing it, given what's going on actually at the moment. But there we are. It is what it is. I just hope that the individual integrated care boards have got good leadership in place, where they look at the regional stats, the regional data, regional fault lines, and they figure out how they can improve the experience for citizens. I think if we keep that at the forefront of our minds, then we've got a chance, But this centralist national nonsense, management speak, just gets us nowhere, I'm afraid. Sorry if anybody's on the call from NHSE, not your fault, I know. All right, there we go. We've done for today. We've got another meeting starting very shortly, Digital Technology Meet, and we'll see you all there if you'd like to come along. Thank you very much. Kris, once again.
All the best.
Thank you.
Cheers,
Thank you, everyone.
Bye-bye. Bye-bye.
Bye-bye.